Welcome to the second meeting of the Senate Standing Committee on Health Services. Just a couple of housekeeping items before we get started here. I'd like to remind everyone to silence your cell phone if you have not done that already. And secondly, if you're interested in testifying on any of the items on our agenda today, I'd ask you to sign the sheet that's provided in the back of the room in the podium over there. But I will mention that testimony may be limited at the chair's discretion in consideration of time constraints that we work under, because we just have an hour to do this. So we'll try to be respectful for everybody's intent to testify, but I can't guarantee that that can occur. And committee members, if you feel it necessary to explain your votes, please limit that to 2 minutes, because again, we just got an hour conducting business here. So remember, we try to endeavor to start on time and end on time. Anyone have any guests this morning? If not, I have one, Miss Rosa Hart, who's, please stand, Rosa, so I can introduce you. She's a stroke navigator with Norton Neuroscience Institute, and she's been asked to shadow with me today to learn a little bit about the legislative process as part of the Kentucky Nurses Association's advocacy project. So glad to have you more. If you would, please welcome Rosa. Thank you, if you would, please call the roll.
Senator Rocky Adams, Senator Berg, Senator Carroll.
Here.
Senator Douglas.
Present.
Senator Herron. Here. Senator Mills. Senator Nemes.
Present.
Senator Rawlings.
Here.
Senator Tishner. Here. Vice Chair Richardson.
Here.
Chairman Meredith.
Present. We do have a quorum due to constitute to conduct business. Slight deviation from the agenda. I want to do the consideration of referred administrative regs first, which were previously distributed to you. I will note to you that the first one, 201 KAR 2.480, they've asked for that to be deferred, which we will do. And on the last two sections under 907 KAR 1044 and 907 KAR 15005, both these regs were found deficient. So we'll just make note of that. Does anyone want to speak on that today? Seeing none, then we will consider these regulations to have been adequately reviewed. With that, we'll move back into the formal agenda. And the first bill will be my own, and I will ask Senator Richardson to assume the chair. And this is his first time to get the chair of the Health Services Committee, and so I know we're all excited to.
No pressure. Thank you.
Make it easy for you to get around. Yeah, how are we going to dance here?
Yeah, it's okay.
Yeah.
Mr. Chairman, if you could introduce yourself and present your bill, please.
Well, good morning, committee. I'm Steve Meredith. I'm State Senator of the 5th District, and I appreciate the opportunity to present to you Senate Bill 13. And some of you who've been on this committee before, this is like a Groundhog Day all over again, because I think this is the 6th or 7th time I present that bill in my going on 9 years in the Kentucky State Senate. And but I don't make light of this whatsoever. This has been an endeavor of mine and a passion of mine for several years because a couple of things. One, the cost of health care in the United States. And if we're not alarmed by that, then we're just not paying attention at all. Right now, we're spending 18% of our gross national product on health care in the United States. That's double, 3 times what other nations are spending. Per capita, we're spending about $14,570 for health care in the United States. Next closest nation, and that's 18% of our gross national product, next closest nation is Germany, which spends $8,100. And this is about 13% of their gross national product. In our major economic competitor, China, they spend right at $900, 5% of their gross national product. We cannot be competitive in an international market with these kind of disparities in healthcare costs. And if it continues, then our system is going to collapse. But, Mr. Chair, before I get into the substance of the bill, I will note that I have a committee sub, And I'd ask for approval of that sub.
We have a motion from Senator Rocky Adams and a second from Senator Douglas. Can we ask for a voice vote? All those in favor, please say aye.
Aye.
Any opposed? There are none. Thank you.
Thank you. You know, again, an alarming increase that's crushing working families right now. The average health care premium for a family right now is in excess of $25,000. And I know our caucus is very excited about reducing personal income tax in Kentucky, and we've made some great progress in that area. On this latest tax cut that we implemented or passed this last week, we're putting about $1,500 more each year in families' pockets, and that truly is impactful. But just think if we could reduce health care costs, and I think potentially I'd like to see a 30% reduction. That won't get us where Germany is, but get it very close. But if we were able to do that, we could put over $7,000 a year back in families' pockets. Now, you might say, well, how's this impacting Medicaid? Because people don't pay premiums for Medicaid. I imagine in 2017, our Medicaid budget was $10 billion. And I said at that point in time, and I still believe this very sincerely, that there's enough money in the healthcare delivery system in the United States to take care of man, woman, child in this country. We spend it the right way, but we don't. Roll it forward 8 years, 9 years, and our budget's approaching $20 billion for Medicaid. Again, we can't continue this trajectory. We got to change that. And how do we do that? We look at the drivers of healthcare cost. And the low-hanging fruit to me is the administration that's associated with healthcare delivery. We're spending about 30 cents of every dollar just on the administration of healthcare. Again, that's double what other industrialized nations are spending. If you do the math very quickly, you see that per capita, that comes out $3,000 to $4,000 per person. And for our Medicaid program specifically, you know, we talk time and time again about that we don't have a single provider category that feels they've been paid adequately, and I agree they haven't been paid adequately. So how are we going to reduce that burden for them? In addition to that, you know, they lose on every Medicare or Medicaid patient they see. How can you continue? Well, again, if we focus on the administration of healthcare, it does a lot of things. It can improve access to care. It can help stymie the problem with inadequate reimbursement. It can make it more customer-friendly, patient-friendly. So that's why I propose only having 3 MCOs rather than we had 6. But, you know, the recent lawsuit by Anthem, the judge found that they weren't going to be a participant, so we currently have 5. But that's still too many. Federal government only requires 2. But I ask you, why do we have 5? What's the magic number here? And I've asked that of our cabinet is, why 5? Why not 4? Why not 7? Why not 8? There's no magic to this other than raw numbers. And I point to California. With our MCOs, we're averaging about 750,000 recipients per MCO. California has 26 MCOs, of course, a much larger population. They average about 1.6 million per capita for theirs. And we know insurance is a risk business. And the more covered lives you have, the more you can mitigate your risk. And I really think with our current situation, because we have so many MCOs, it limits the number of Medicaid recipients for insurance, some insurance companies, it puts our program at overall financial risk. So, you know, that's another reason I'm proposing this. But it does so many things. You know, one of my biggest complaints about our healthcare delivery system in Kentucky is rural healthcare. Obviously, I preach about that constantly. And I give you a lot of what I call damning statistics, but I think the worst one is that 40% of our population lives in rural Kentucky. Only 17% of our primary care physicians are there. What a travesty, what an injustice that is. And how are we going to impact that? I don't know. We've got several proposals. We're trying to, you know, address that. We've got a shortage of healthcare professionals, but a bigger issue is the fact that you're going to be making 25 to 30% less than your urban counterparts by going to a rural community. And how can we impact that? We should be able to impact that. So this is one way to do it, just a small measure. But I was talking to a primary care physician last session, and I asked her, how much time do you spend every day just on the administration of your Medicaid population? She said, easily 2 hours. You know, this is when we have 6 MCOs, you're spending 2 hours a day, if we could reduce that in half, then maybe we could reduce her time in half, and she could save an hour a day. May not seem like a whole lot, but that's 4 more patients that she could see. 20 a week, 80 a month, almost 1,000 patients visits a year. And you multiply that by every healthcare provider in Kentucky, and suddenly you're making some inroads into that. Not where it needs to be, but it's a small step forward. Again, this is creating a burden of healthcare providers that just is not sustainable, particularly in rural communities. And let me read a couple of quotes from you from Medicaid providers. It's one: we sent a request for an independent review to appeal an audit finding recoupment for services provided in 2019. We received a letter from the Cabinet for Health and Family Services on 7/8/22, 3 years later, letting us know that they were forwarding our request to the Island Peer Review Organization. As of today, this is 12/14/22, we still do not have a solution. Had to hire an attorney to help us. Imagine doing that for 6 different audit findings. It's exhausting, and it truly is. And I know some of the larger systems, they can actually have people who are dedicated to each MCO, but when you're a small provider, particularly in a rural community, you don't have that flexibility. And you can't fight those kind of denials and go through the appeal process. We heard testimony a couple of years ago from a mental health provider that was in a rural community serving, I think it was a 5-county area, maybe 7-county areas. And she said she had an MCO audit, which you have to do as part of the program. First audit found no deficiencies whatsoever. A couple of weeks later, she had a second audit, and they found out she owed them $25,000, which she could appeal. But this is a person that's a small business owner, and 2 years later, still hasn't been resolved. $25,000. How do you survive? How does a business survive under those circumstances? So again, just trying to bring some sanity to this, Mr. Chairman. There's no justification I can see whatsoever for having this redundant bureaucracy here. So I beg and plead, let's reduce this to a reasonable number, which I think is 3. As I said, I'd like to do 2, but federal government just says we have to have 2 just to give this thing some flexibility. Because one of the arguments I've heard is, well, what if one of the MCOs pulls out, like what happened back in 2012 when we instituted this program? So my compromise is 3.
Thank you, Mr. Chairman. I think we've got a few questions. We'll start with Senator Byrd.
Thank you, sir. Good morning, and thank you very much for bringing this to our attention. As a state, do we have any data comparing the individual MCOs to each other as far as denial rate, turnaround time? Are they servicing the population they're supposed to be servicing in a reasonable manner? Is there a way for us to gauge that?
There are measures within the contract to monitor performance, but monitoring performance is not the same as requiring performance. And there's some great deficiencies in the enforcement of those contracts that we're going to have to address in the future as well.
In my experience, just a brief, with some of these MCOs, they do not seem to feel obligated to us. They just seem, honestly, to be sort of making their own rules. And there doesn't seem to be any way to control that.
Well, one of my favorite quotes is, it's not about the money, it's about the money. But you're so right. And I know we have several technical advisory committees that are supposed to try to monitor this on a broad basis, but I don't know that they have an effective voice either, that they truly just ignore what the contracts say. We heard testimony a couple of summers ago when we had the Medicaid Oversight Advisory Committee. We let each MCO talk about their service and what they were doing, and one of those measures is network adequacy of providers. And every one of them, we got this covered, don't worry about it, we're there, which obviously very suspect. You and I know it's very suspect, but I asked Dr. Stack, our Commissioner of Public Health, I said, here's what was said, do you believe that? And he said, and I'm not trying to throw him under the bus, I think it's a fair assessment. No, there's not network adequacy. And it's particularly more pronounced in rural communities.
Follow-up please? I think there is a real argument to be made that if we limit the number of MCOs, we might be able to stay on top of what they're doing better.
I would agree. We spend literally millions of dollars auditing them and doing actuarial analysis, and the fewer of those you have to deal with, the more money you can save.
Thank you. Senator Herron?
Thank you, Mr. Chair, and thank you for bringing this bill. I am not as familiar with this issue as maybe others on this committee. My question is how will reducing the number, how will it impact patient care, or will it have a direct impact on individual patients?
I don't see it has a direct impact on it. It has an indirect impact if we have more access to care. And again, in rural communities and urban disadvantaged communities where you got a shortage of providers, it reduces their administrative burden, administrative time dealing with those issues. That means they have more time to spend with patients. My son is a primary care physician, and he told me recently he was trying to get approval for a procedure that should have been like a slam dunk. He said, I'm 45 minutes on the phone trying to get this resolved, and I should have been seeing patients. But that's an everyday occurrence. And when we expanded the Healthcare and the Affordable Care Act, great in theory, but the requirements that went with that from a bureaucracy standpoint, such as electronic medical record, which there wasn't a good one at the time, physicians now had to do that, and it slowed down their productivity 25 to 30%. And at the same time, we put 25, 30 additional % patients in that mix. So fewer patients can be seen because of this administrative quagmire that we've created with this program.
Thank you. Senator Douglas?
Thank you, Mr. Chairman. Senator Meredith, this is more of a comment than it is a question. I really think the statement that you made regarding the administrative physician time is pretty darn accurate. But one of the things I want to point out is it doesn't even touch on the added cost to medicine when you have to hire more people to get the pre-authorizations from MCOs that are choosing to use different criteria for which they offer that pre-authorization. It is incredibly confusing. And with respect to cost of medicine, or even let's say the access to the health care, we don't even talk about the patients who decide not to go to the doctors because they can't get what they need pre-authorized because those physician offices are working so hard with the different procedures to get pre-authorization from the multiple MCOs. So if we want to talk about something that is inhibiting access to health care, we have to plug that into the equation. Thank you, Mr. Chairman.
We most certainly do. And, we have to address this. The low-hanging fruit to me is the administration portion of it, and the other is improving the health of the population. If you don't have access to care, then you can't do that. But the third is just a more efficient program. You all understand that for Medicaid, they don't pay the full cost of care. So where's that go? It's a pass-through to commercial pay insurance. That drives up healthcare costs, and I'm amazed that on a national level, there's not more discussion about that. It's a hidden tax. And the less that Medicare and Medicaid are willing to pay in terms of costs, the more that's shifted to the consumer. So this, even though it's a Medicaid program, this directly impacts the cost to the commercial pay patient as well. Drives up that cost.
If there are no more questions, do we have a motion on the bill? Second. All right. We have before the clerk calls the roll, I just want to remind everybody, when you cast your votes, please cast your vote first. If you have comments, please limit them to no more than 2 minutes. Please call the roll.
Senator Rocky Adams. Senator Berg. Senator Carroll.
Aye.
Senator Douglas.
Aye.
Senator Herron. Senator Mills. Senator Nemes.
Aye.
Senator Rawlings. Senator Richardson. Senator Tishner. Chairman Meredith.
Aye.
10-0. Passes favorably. Thank you so much.
Thank you. Looking forward to presenting this on the floor. Appreciate your support. Thank you.
I will make my way down to the table now and turn the time back over to Chairman to present our next item, Senate Joint Resolution 26.
As noted, the next item on our agenda is consideration of Senate Joint Resolution 26. And Senator, if you would, please identify yourself for the record and proceed.
I'm Senator Craig Richardson. I represent District 3, and I'll let him introduce himself, but I'm joined with a backup from the Pharmacy Association today.
Good morning. My name is Ben Mudd. I'm the Executive Director of the Kentucky Pharmacists Association.
Mr. Chairman, and members of this committee, I'm happy to be with you today. This is something that I've cared about for quite a while. This Senate Joint Resolution simply states what a goal of the General Assembly can be, and that is fair reimbursement from Medicaid and K-CHIP to pharmacists that are providing clinical service already existing in their scope of practice. So that's my first bullet point, that we are not expanding the scope of practice for pharmacists. In this Senate Joint Resolution, what it really does is it directs the Department of Medicaid Services to provide us, during this interim, that we will have data and cost analysis of what it would look like to implement a bill that would then provide for payment parity or fair payment to pharmacists under Medicaid and K-CHIP. I'm not saying this because I'm married to one, and I'm not trying to get brownie points, but I truly mean this, that I think I know pharmacists are integral to our healthcare system, especially here in Kentucky. As Chairman Meredith just spoke of, about the impact of rural healthcare throughout the Commonwealth, and the access to healthcare and the barriers that exist in the access to healthcare. I know pharmacists play a role in their local communities, and one, providing a relationship with the community, and number two, in their existing scope of practice, having the skill set to provide care in various ways. Some of those things are medication therapy management, chronic disease management, and preventative care. I want to highlight that last piece in preventative care and how important it is for us to be proactive in healthcare and allowing the access for patients in their local communities to get access to healthcare. Take a strep test, for example. These patients can go to the ER if they're feeling symptoms of strep or the flu, and they can certainly be treated there. And we as a Commonwealth, and as we just discussed, the MCOs, and that reimbursement rate will pay that reimbursement rate, which is a higher rate. They can also go to their pharmacist. They can have that access to care and take care of those things with their local pharmacy and receive preventative treatment that has a myriad of advantages. They don't have to miss work as much. They don't have to schedule an appointment with primary care, and they don't have to go to the ER for increased rates. So again, we are looking to create an alignment and create a continuity of care and create an opportunity for rural healthcare to have as much access as possible. We're not increasing outcomes. The flu doesn't go up just because you have pharmacists doing this. This just gives them one more advantage as a patient to receive care and testing. We approached this a little bit in 2021 with House Bill 48 that was enacted on the commercial insurer side. It was a little bit of an odd year with COVID and a short session to be able to implement this fully. So this is an opportunity for us to come back and look at this. Again, this isn't the bill. This is us asking the cabinet or the Department of Medicaid Services for the data so that when we are ready to present a bill, we are fully informed. We don't think this will increase Medicaid costs, but that we know that this may have a cost for the administrative side in setting some things up, although we don't feel that it would be significant. But we want to do our due diligence and know what those things may be. So just to put the bow on it, if you will, this is a Senate joint resolution that asks the department to provide data to us during this interim. I think it's August 1st, so that we can discuss it in the interim fully vet out the opportunities that this can create to create a payment parity or a fairness in payment for Medicaid and K-CHIP to pharmacists in the community to increase access to care and opportunities for a healthier outcomes in our communities.
There's a motion second, but I do have Senator Douglas who wants to make a question, comment? Yep. Yes. Yes, please.
Thank you, Mr. Chairman. I just want to make sure that I'm understanding what's being presented, and Mr. Mudd, maybe I should direct this to you because something you said, Senator, really changed how I was going to ask the question. But my question was essentially going to be, do we have study results that would provide us with information whether expanding the pharmacy duties in the recent past have either increased access or increased access to health care or have improved patient outcomes? Is it my understanding that you want that data, that you all are asking for that data so that those particular assessments can be made?
I'll just answer part of it, and then I'll let Mr. Mudd. We're not expanding the pharmacy's role. They're going to stay within their scope of practice. So I just wanted to be clear on that.
But my point is that scope of practice has been expanded, and we have not assessed or had the data or talked about the data as to whether that expansion of that scope of practice has either increased the access to health care, which is one of the reasons that the expanded privileges were asked for in the first place, or has improved health care outcome, which again was another reason why it was requested to have the expanded privileges. My question is that what this data is going to help us be able to determine?
So the data will look at Medicaid's anticipated cost to use these services. And to answer your question of has it increased access, I think it's increased access to those that can afford it. So right now,
Do we have any data that suggests so, as
so-
opposed to anecdotal data?
Well, the Board of Pharmacy does track how many pharmacies are using the protocols. I don't have the exact number of how many pharmacies are using it, but we can certainly get that back to you. And I don't know that there's a published number of like encounters that have happened. And I think it varies on the community. But just speaking with our members, we know that the protocols are being used, but they are being used primarily on a cash basis because pharmacies are not able to bill insurance for them.
Okay. May I, Mr.
Yes,
Mr. Chairman? The only reason I mention that is because we continue to move the ball forward for particular areas, but we don't really go back and take a look at whether or not it is actually doing the things that we are initially are suggesting that these things will do. And I think at some point we need to put the brakes on and actually ask the question, are we getting the results? Are we getting the return on our investment that we anticipated that we would in order to continue to move down that road? That's all I'm saying. Thank you, Mr. Chairman.
Well, I think your position is well spoken, and I would agree with you. But I would think, Ben, what I would challenge you all to do as part of this report is we look at that, because Senator Douglas is so correct. We get a lot of requests for additional payments for services, and I don't know that we ever do a very good job of measuring what the impact of that is, and we need to. And for everyone, for every dollar we spend on the Medicaid program, they're precious dollars. We have to be able to justify that we've got some return on investment. If not, then we can't go there. So again, I would challenge you, if this resolution is passed, to make it encompassing to look at that particular issue that he's given us, because it's important.
Absolutely. Yes, sir.
Thank you.
There's a motion second. Please call the roll.
Senator Rocky Adams. Senator Berg.
Aye.
Senator Carroll.
Aye.
Senator Douglas.
Aye.
Senator Herron. Senator Mills.
Aye.
Senator Nemes.
Aye.
Senator Rawlings.
Aye.
Senator Richardson.
Aye.
Senator Tishner. Chairman Meredith.
Aye. Vote is 11-0. Resolution, the bill on the resolution passed in favor of expression. So appreciate you being here, and I look forward to the report in the future. Thank you.
Thank you.
Before we get on our last agenda items, do we have any member who would like to cast a vote for, not the reporting out to Senator Mills, but would you like to cast a vote for Senate Bill 13?
Mr. Chairman, I missed a great discussion, I'm sure, and vote on a great bill, so I vote aye on Senate Bill 13.
Thank you. I can come out of your office and give it to you again later if you'd like. Next item on our agenda is Senate Bill 27. And I ask those folks to come forward. And I remind you again that this is for discussion purposes, and the reason being that I spoke last week about how I want to see this committee function in the future, and it's my contention we see too much legislation that's not properly vetted. And Senator Storm and I have had that conversation. Is I really like to hear more of these things in the interim, so we have more time to consider them, question them before we move on. And I make an exception for him today because we have a slight agenda and we can devote some time to it. But we're not going to act on this bill today, so he has the time to present his information. But then also, committee members, you have the time to follow up with him if you have any questions, concerns, and we can possibly move on that the next time we meet. With that, Senator Storm, if you would, please identify yourself for the record.
Thank you, Mr. Chairman. Brandon Storm, Senator of the 21st District, encompassing Laurel, Rockcastle, Lincoln, and Casey County.
And you have a guest?
Yes, Mr. Chairman.
Jane Rice Williams. I am the executive director and founder of Parkinson's in Motion, a 501c3 nonprofit that's located in Eastern Kentucky and serves Appalachia.
Appreciate both of you being here this morning. Please proceed.
Thank you, Mr. Chairman, members of the committee. Thank you for allowing us to present to you Senate Bill 27, which is a bill designed to create a Kentucky Parkinson's Disease Research Registry. Today, we anticipated having our colleague who's worked on this with us from the Michael J. Fox Foundation present, unable to be here due to the winter storm that hit just yesterday, and she was unable to fly here. So we did submit to the committee members her letter that's in the packet. I did want to address something in her letter right now, draw the members' attention to. The reason this registry is so important is if you'll look on the third paragraph of her letter, and this is her letter if you're looking in your packets. But the third paragraph, as the testimony has been here today, 1 million Americans currently live with Parkinson's. 90,000 are diagnosed each year. And that is statistics from the Michael J. Fox Foundation. So we're talking about health care costs. And if you'll notice in that same letter, it points out that the annual cost of Parkinson's nationally here in the United States is at least $52 billion, and it's estimated to rise to approximately $80 billion by 2037. The next paragraph I think is extremely important for this committee because here in Kentucky, the direct and indirect costs of care for over 15,000 people who have currently diagnosed here in Kentucky living with Parkinson's disease is about $725 million a year that we're spending out on our constituents. So it's extremely important that this piece of legislation moves forward so that we can do exactly what this committee has been talking about today, return on investment. What this bill does, very briefly, it creates a registry that would be overseen by the Cabinet for Health and Family Services. It's important to be there because we already have the infrastructure in place in that entity for stroke registries and cancer registries, and this would study the incidence and prevalence of Parkinson's-related diseases and other disorders underneath that heading. It also creates an advisory committee, and that is outlined in the bill on page 2, paragraph 3B. It has a neurologist, movement disorder specialist, primary care providers, physician informationist, a patient living with Parkinson's disease, public health professionals, a population health researcher familiar with health data registries, and Parkinson's disease researchers. What that will be able to do is use those experts in that field to help us come up with ideas as to what's working, what's not working. It also requires data collection and reporting starting in 2026. This is important for our patients, our constituents, because what it is, they would be enrolled in this, but each person has the opportunity to opt out of this program. Everything would also be used only for research purposes at this point. And again, it talks about scientific research with strict protections in place for patients' consent and confidentiality. So they're not going to have Social Security numbers, they're not going to have photographs, they're not going to have personal identifying data associated with this research. The next thing I think is important for this committee and the General Assembly, because as we've heard today, return on investment is extremely important to this General Assembly. And what happens with this bill, starting in October 1st of 2026, the Legislative Research Commission is to prepare a report regarding this registry. More importantly, that report is to come before the Interim Joint Committee on Health Services so that you all can study whether or not this is working, what the prevalence is, can we change things, and again, we're relying upon the experts in the field. Next, it also will require public access. So beginning October 1st of 26, a dedicated website so people in the public can go in and look at, what are the numbers, what are the statistics, and that way the public can see what's happening with this registry. Again, no personal identifying information would be available, but again, allows the transparency and accountability of the registry. So at this point in time, I'd like to turn it over to my colleague for her comments.
Thank you. I was diagnosed with Parkinson's disease on October 26th of 2016. I was working as an administrative law judge for the Department of Workers' Claims, and I was shocked. I was in Lexington. I drove home to London. My husband came home from work. We both just cried all day because we didn't know what it was all about. We didn't know what was going to happen. We didn't know what the future was. But the next day I had hearings, and I started not to go because I looked horrible, first of all, from crying all day. But, I knew if I didn't go that day, I'd have to go at some point. So I got up and went, and had a gap between hearings that day. And at some point, just within 24 hours of my diagnosis, I felt a peace, and I felt a drive that something was in my future, and that it had to include me being a person with Parkinson's. So we got to work, and we learned everything we could. And the sad thing is, we learned there were very few resources. Nothing for anyone outside of Lexington, Louisville, the cities. And our group focuses on the region in Appalachia. But when Senator Meredith mentioned how few doctors there are addressing things, there are almost no neurologists in Eastern Kentucky, and even worse, there are no movement disorder specialists, and Parkinson's patients are required to be treated by movement disorder specialists. I have today with me Erin Caldwell. Erin, if you'd wave. She's with American Connection Corps, and she's full-time with our organization, which has meant everything to me and to our group. We also have with us Kelsey Lewis. Kelsey and her sister Rebecca. Kelsey lives in Lexington. Kelsey and Rebecca's father died in October with Parkinson's disease. And it's just, in 1817, Dr. Parkinson's noticed these 6 men getting off a train with symptoms that they'd never seen before. They'd seen tremors, they'd seen this shuffled gait, but never in the same person. That was 6 men. We're now up to the number 1 million people in the United States is a conservative number. So many people are not diagnosed. The fact that this registry and that people in Frankfurt are talking about Parkinson's disease, that's what makes me want to cry with joy that it's finally being looked at. This is a first step, but wow, it's a big first step for us to recognize that we have to do something about this. And let me tell you something else. You can have Parkinson's in your system 20 or 30 years before you start to know you have it. So I'm telling you, some of you all have Parkinson's. The numbers are just will confirm that. So I'd like to know if any of you all have any questions for us.
Senator Carroll, you have a question, I believe.
I do, Mr. Chairman.
Thank
Thank you. And thank you all for bringing this bill forward. Help me connect the dots on this. I understand the data collection part and, the parameters set with that. The advisory committee, I guess, being responsible for coordinating that and pulling all that data together. The bill does not mention research. Will the advisory committee kind of be the entity within the state that any research entity would contact to be able to access this data? Or what are, I mean, there's 3 stages: collecting the data, putting it all together, and then actually using it for research. That final piece with the research, how does that happen?
Well, thank you for the question. You're correct. I think what would happen is this entity, this advisory committee, would come up with, regulations to govern how they're going to do this. And I think it would be on page 3, paragraph 6, line 18, develop guidelines and procedures for reviewing and approving requests for the registry data and valid scientific research. So again, this advisory committee, who are experts, I'm not an expert in the field, and I think the way this is formulated is this is working in I think multiple other states right now. Kentucky would be the 15th state to do something with the registry, and so it's working in other states, and it would again put experts in the field that would be able to come in and say, look, let's study, here's the data, let's study this issue. I don't want to necessarily direct them to do something or not to do something. I think they're the experts in the field, and I think in Kentucky also I received information there's 326 neurologists in Kentucky. I believe we passed House Bill 1 not long ago, and it might enable the University of Kentucky, for instance, the University of Louisville, to collaborate on research, but that's the underlying goal, is to try to get all this research out, or the data back out to the researchers.
And that was my next question, whether or not UK or U of L has discussed the possibility of initiating research in this area.
I can say that at this point, this isn't really a conduit to research, but it will be. We've got to start somewhere, and there are plenty of doctors at UK, U of L, Norton, that are so ready for this to happen, because doctors in my town and in my area call me if they have a patient in there with certain symptoms, and they'll say, what do you think? And I'm get them to UK or get them. There's just so little, nothing addresses this just extremely fast growing condition. And we've got to start somewhere, and this is the very best place to start. Let me mention that Michael J. Fox has done more for Parkinson's research than any one person, and he's Canadian. We appreciate his contribution. But
That's a state now, you know.
So, yeah.
Thank you, Mr. Chairman.
Senator Mills.
Thank you, Mr. Chairman. I'd just like to thank Senator Storm for bringing this to light. My dad and business partner died of a rare type of Parkinson's called supranuclear palsy. And he went to a neurologist probably like 4 years before he passed away. And the neurologist said he'd only seen it like 2 or 3 times. And he was immediately able to diagnose it. And I really think it gave him a higher quality of life the last couple years of his life. So I appreciate you bringing light to this, and hopefully we can give people a better quality of life with Parkinson's. So, thank you.
Thank you.
You know, exercise is the only way to slow down the progression. And as you all look at me and you think you seem like you're doing fine, but I'm losing dopamine every minute. I'm continuing to lose it, and at some point that's going to take over. But I'm 69 years old, and when Senator Meredith talked about being here 5 times on the same thing that he's discussing, and I think next year I'll be 70 years old, and we're still doing nothing in this country. I don't want to, in this state, and I don't want to have to keep waiting on that.
Senator Richardson.
Just real quick, and this is just for my education purposes. First of all, thank you so much for yourself to be here and advocate, for the family being here. Advocacy is where the rubber meets the road here in Frankfort. So thank you so much. 15,000, is that low, average, high for the state of Kentucky for those affected?
Based on my experience, it's going to be low because we have quite a few in our area, and numbers are all over the boards on this, but nobody argues with the fact that it's the fastest growing neurological condition on the planet.
Compared nationally, I guess, at a per capita or ratio base, are we average with numbers, or?
We have some research that shows that Appalachians are at a higher risk. All of that is still, that's all still not really known.
Thank you.
Senator Adams.
Thank you, Mr. Chairman, and I'm very supportive of this initiative. Several years ago, we passed the Rare Disease Advisory Council with the sole intention of setting Kentucky up to be able to qualify. Once the state says that we're ready to look at these things, we were now able to bring in those research grants. We were now able to coordinate data collection. We were able to coordinate. There's a whole host of things out there that Kentucky doesn't have access to. And so I view this as a really incredible initiative where we are saying as a state, this is important to us and we're open for business and we want to start to research this. So I really applaud you and being here today, and I think this is a really positive step forward. So I would look forward to helping you in any way I can. But check out that Rare Disease Advisory Council because we did it a few years ago and it's been extraordinarily successful.
Thank you.
Thank you.
Senator Berg.
Thank you for bringing this. Thank you very much. I think we had a chance to talk on the phone yesterday, and my father died of end-stage Parkinson's, and it is eventually a debilitating disease. We have here in this state a cancer registry. We have a trauma registry. I'm familiar with both of them from a medical perspective, and they offer a tremendous amount of information for where we need to be looking, what we need to be focusing on. And the truth is, with Parkinson's, it may be more than one disease. We don't know that yet. It presents differently in different people. It presents sometimes in clusters, which makes you think, maybe there's something in the environment that may be producing this. It's a very debilitating disease that takes good people. And to have the data as to where we're seeing it, what age group, what part of the state, how they're presenting. If we had that data nationally, we could be making really great strides in trying to figure out what's the chicken, what's the egg, where do we start with this? So thank you. I'm 100% on board.
Thank you.
I honestly wish we could collect this type of data for all of the major medical problems that we see, because that's the first way of addressing them, is finding out where is it.
Yep.
That matters tremendously.
Right.
Well, thank you for your advocacy. I truly appreciate the effort you're putting into this. And I'll have to admit, though, that I'm not a real big fan of data collection because we don't do anything with the data we collect. So I don't think you're trying to put something in place that we would do that. But to that end, have you had any conversation with the University of Kentucky, with the Neuroscience Institute? Because I know they focus on Parkinson's to some degree. I don't know what to extent, but have you?
Absolutely. I have the cell phone numbers. I can't share that information right now, but yes.
I would expect you to. But what I suggest is maybe, again, this is a kind of preliminary hearing. I think we can take action on this session, but it's possible maybe the next time they could come forward and give us some insight as to how they think this would work and what kind of relationship we could build with them. Mm-hmm. Would that be possible? Mm-hmm.
If they're willing to allow that, yes. I'm not sure the parameters that they would have to jump through in order to come to the table and speak in favor of the bill or not. But I will contact them, and I know that's she's been in a lot of communication with University of Kentucky specifically. They did send an email requesting some clarification. I did want to share this with the physicians and those who have family members that are in the practice. So this is only going to, the reporting requirement would only apply to diagnosing or primary treating physicians for the individuals with Parkinson's, so not the 10,000 physicians throughout the state, but more specifically the 326 neurologists who primarily treat these individuals. Those would be the individuals who would be included in this. So I think that with having the health information exchange, that would also be able to be utilized between the University of Kentucky and the University of Louisville, and it would cut down on expense and things of that nature. But I will have that conversation.
Well, we're not without data. It's probably not as complete and concise as we would like. CDC collects some of this information in state specific. Is there some holes in that data, or are we trying to?
Can I explain that Parkinson's, as Senator Berg mentioned, it is what they call a snowflake condition. It presents itself in so many different ways. It all stems from a loss of dopamine that happens in this substantia nigra area of your brain. But it's very snowflake, and it makes it that much harder to, gives it that much more reason why we need to collect as much data as we can so we can start figuring it out. By that time, they made us, well, I don't want to talk too much about what the medical profession is going to do, but the collection of data is crucial to see which direction we need to go.
Senator or Chairman, if I may, and again, the CDC is a great resource, but I would prefer that we have the information here before this body, because on page 7 of the bill, paragraph 12, line 13, beginning October 1st, 26, each year the Cabinet shall submit to the Legislative Research referral to the Interim Joint Committee on Health Services a yearly program summary update that includes a whole list of things for you all to be able to review. And we're not just relying upon another entity to tell us information, or we can request it. We might never get it. This would enable us, you all, to get the information right here at your fingertips.
And to that end, since you mentioned the Cabinet, there is an expense associated with this. I've talked to them informally about this, but have we requested a fiscal note on this?
I have not.
Why don't we do that? Again, I'm going to invite you folks back. I don't know, we'll do it next week or the week after, and we'll move this forward, but I think we need to know that information. I think the preliminary numbers they gave me were something like $800,000 per biannual, but I would like to formalize that just so we know what we're dealing with here, if we could.
Sure, and to that end, I have a list of other states. Maryland, 129,000, Massachusetts, 100,000, Nebraska, 20,000. So again, I'm not sure about what the Cabinet's numbers are or how they're based, but I haven't seen those. But I do appreciate the question.
Any other questions, comments for our presenters? If not, sincerely appreciate you being here. Look forward to our continued discussion on this, and been a great discussion so far. And if there's nothing else, folks, we'll stand adjourned. Okay?
If anyone has any questions for me or wants to call me, please feel free to do so.
Thank you.
Thank you.
And I'll try not to get you on the treadmill next time, okay?